Today our topic for discussion is asthma in pregnancy. This is a reference is talk article published in 2013. So now we have to discuss the asthma in pregnancy. Key content: asthma is a common condition that affect 10% of the pregnant women. It may become as an SPA that how much it affect a pregnant woman 10%. And the second one is pregnant women worsen asthma control in one third of the patient, improve it is in one third and have no effect on one third. So you have to memorize this that one third worsen, one third improve, and one third no effect. So this could be also one of your SPA that how much it worsen and how much it improves. So poor asthma control has adverse effect upon maternal and fetal outcome. Good asthma management to maintain control is important in line with national guidelines. Standard therapy with inhaled steroids with or without the addition of short and long acting beta agonist can be used. So inhaled steroid short and long acting beta agonists are safe in pregnancy. As though we'll also give this type of medication outside of the pregnancy, but if the patient is already taking these medications, so it is safe in pregnancy, you can continue in collaboration with pulmonologist. Introduction. Asthma affect and 235 million people worldwide, and the burden is likely to rise substantially. The condition causing about 239,000 deaths per year. So, asthma is a chronic inflammatory disease of the airway which is characterized by intermittent episodes of wheeze, shortness of breath, chest tightness, cough, which are often worsened at night. It is a variable disease where inflammation and structural changes occur in the airway in response to certain stimuli or trigger. So the causes airway hyperresponsiveness and variable airflow obstruction lead to symptoms described. So the patient suffer from flare up or exacerbation of their disease either in response to an acute infection, which is usually viral in origin or due to poor control of their airway inflammation. So what are the main symptoms characterized by that is intermittent episode of wheeze, shortness of breath, chest tightness, cough, which are often worsened at night. And what is the prevalence? The prevalence is almost 4 to 12%, making it most common chronic condition in pregnancy. So, what are the triggers for asthma? The triggers are allergens such as house dust, mite, pollen, smoking, exercise, occupational exposure, pollution, drugs such as aspirin and beta blocker. You have to take the detailed history of this type of patient, whether she is a known asthmatic patient, that what allergy is she is having specifically, and you have to tell the patient that you have to avoid if the patient is having allergy to aspirin and beta blockers, so you have to not to prescribe beta blocker or aspirin, especially along with asthma. She is having other condition like chronic hypertension. So in gestational or chronic hypertension, our first line drug is labetalol, but you have to take the detailed history is very important, past history is very important, so you have to change the drug according to the situation. If the patient is hypertensive obviously you and already asthmatic, but you have to not give her a beta blocker because it will further activate her asthma. So these are the important point that why the history is very important in patient, because according to that you will manage the patient accordingly. Foods and drinks such as dairy product, alcohol, peanuts, orange, additives such as monosodium glutamate and tetrazine, medical conditions such as rhinitis and gastric reflux, hormonal such as premenstrual conditions and pregnancy. So these are the most trigger factors for asthma. So then we will discuss the breathlessness in pregnancy. So that is the main, what is the physiological factors. We will basically now we will discuss the what is the physiology. In physiological factor affecting asthma in pregnancy, what happened in pregnancy? Increase in free cortisol level may protect against inflammatory triggers. So in pregnancy, free cortisol increases, so it away the inflammatory triggers. Increase in bronchodilating substance such as progesterone may improve airway responses. So why the asthma improve? Because in pregnancy progesterone increases, and what are the effect of progesterone? They cause bronchodilation. So in asthma there is bronchoconstriction and lead to the symptoms, but the a good effect of pregnancy in that the patient excess progesterone is released, so it will affect on the broncho bronchioles, so it will dilate it, so the asthma will improve in pregnancy in one-third cases. Increase in bronchoconstrictor substance such as prostaglandin F2 alpha may promote airway constriction. So this is the point that we will avoid. For example, if you are planning for induction of labor and you are induced with the prostaglandin, so you have to avoid in a prostaglandin, for example, in case of a heavy pph, and you are giving like prostaglandin pgf2 alpha for control of her hemorrhage, so you have to avoid in asthmatic patient. So in that case, whenever the patient came in labor already and she is not having any antenatal visits, so you have to be very vigilant. You have to quick history from the patient, because whenever this patient gone into pph and you will give her prostaglandin fgf2 alpha like the carbaprost, so it will lead further aggravate her asthma. So these are the point that is very important. You have to memorize this. Placental alpha beta hydroxysteroid dehydrogenase type 2 decrease activity associated with increase in placental cortisol and low birth weight. So you can also, because with asthma there is the baby growth may be affected. So in that case, an asthmatic patient, you have to monitor the patient for growth for to exclude small for gestation age due to this cause, because placenta alpha hydroxysteroid decreases and increase in plasma cortisol level, and it lead to low birth weight. Placental gene expression of inflammatory cytokine may promote low birth weight. Modification of cell-mediated immunity influence maternal response to infection, and so the cell-mediated immunity is decreases. So that's why the mother is more prone towards the infection. So whenever the patient came as a dyspnea, shortness of breath, so you have to exclude other causes as well. Maybe she's asthmatic, that the asthma aggravate, but in that case you will also exclude other causes. For example, what are the differential in dyspnea? That is anxiety, hyperventilation, dysfunctional breathing, respiratory disease like asthma, chest infection, pneumonia, thromboembolic disease, sarcoid or secondary to connective tissue disorder, interstitial lung disease, pneumothorax, amniotic fluid embolism. The cardiac causes are arrhythmias, ischemic heart disease, cardiomyopathy. Endocrine disease are diabetes mellitus, lead to hyperventilation in the setting of acute ketoacidosis, acute thyrotoxicosis, and the other one is hematological chronic anemia, acute hemorrhage, and renal disease, hyperventilation to compensate for metabolic acidosis secondary to renal failure. So whenever, if the patient is not only diagnosed as asthmatic and patient came as a dyspnea, so in dyspnea you have to take the detailed history of dyspnea associated with chest pain, hemoptysis, to exclude other causes of dyspnea that are respiratory, whether this the cause is respiratory, whether it is a cause is cardiac disease, whether it is a renal disease. So these are the, you have to sometime in short case this type of station you have to this type of station usually came as a patient presented with shortness of breath and dyspnea. How will you proceed? So in that case, when how will you proceed? So you have to exclude all systems for dyspnea. So these are the important system that lead to dyspnea, causes that lead to dyspnea. So the effect of asthma will also explain very well in that table. In severe asthma, disease control is more likely to deteriorate 60% than in mild disease 10%. So you have to sometime SBMA came from this point that in a severe disease it will likely to deteriorate 60%, but in mild it is 10%. Respiratory viral infection was the most frequent trigger of exacerbation 34%, followed by poor adherence to inhaled steroid therapy 29%. Then after that, we will discuss the table later on. Then what is the management of stable asthma in pregnancy? We have to discuss this in detail, that how we will manage this patient. Then we will discuss this table properly. In last, first of all, we will discuss the management of stable asthma and unstable asthma. That patient is having stable asthma, what we will give, and those with unstable asthma, what we will start. So the management of stable asthma and the management and treatment of asthma are generally the same in pregnant as in non-pregnant women. I've already discussed this. The intensity of antenatal maternal surveillance should be based on the severity of asthma. For example, the current need of therapy, symptom control, exacerbation, frequency include high dose steroid usage and hospitalization and lung function. For example, peak flow and spirometry together with the risk of fetal complication. So, the journal principle for asthma management in pregnancy are summarized in box 4. Women with moderate to severe asthma, step 3 or above, need to be managed by both a respiratory physician and obstetrician to optimize asthma control. So it is a because is a chronic medical condition, so you will involve both the respiratory physician, means pulmonologist, as well as obstetrician to collaborate both with each other, multidisciplinary team, and manage the patient accordingly. So what are the non-pharmacological management? Non-pharmacological education is a cornerstone of asthma management. You have to tell the patient that avoidance of trigger factors that adequate use of devices and avoid dusting because and pollen allergies, food allergies, avoid that of drugs that lead to allergies, and avoidance of dust. So these are the trigger factors that she may avoid. Asthma control, adequate use of devices, and the importance of adherence to medication together with construction of personal action plan. So you have to tell the patient that she should have to continue her medication and to adhere with that, because if she is not adheres with that, that lead to further exacerbation. Then after that, what are the pharmacological treatment? So we have to discuss the pharmacological treatment in this table. They have explained very good in this table that how you will move up and move down, how you will control the asthma. So whenever the patient came as initially the step 1, as a first time she came with the she diagnosed with asthma, then you have to initially start with inhaled short acting beta 2 agonist at required. Mild intermittent asthma, in mild intermittent asthma you have to start her on short acting beta 2 agonist as required. If it is not controlled with that, then you have to step up. What you will do in step 2, regular preventive therapy, that is add inhaled steroid 200 to 800 mcg per day, or 400 microgram is an appropriate starting dose for any patient. Start at dose of inhaled steroids to appropriate severity of the disease. So with inhaled steroid, inhaled short acting beta agonist is not controlled with this drug, then you have to add steroid, but you have to add the steroid in inhaled form, not in oral form. So the dose will be 400 microgram. And if with these two drugs not controlled, then will further step up. What will we will then inhale long acting beta 2 agonist from already she is taking short acting, but it is not controlled. Then you have to add long acting beta agonist and assess the control of the asthma. Good response to long acting, you will continue, but benefit from long actings and still inadequate, then you have to increase the steroid dose up to 800 microgram per day. And if not already on this dose, so if she is taking 400 microgram, then you have to increase the dose up to 800 along with long acting beta 2 agonist. Then if no response to long acting beta 2 agonist, stop long acting beta agonist and increase inhaled steroid to 800 microgram per day. If control still inadequate, institute trial of other therapies like leukotriene receptor antagonist or SR theophylline. So initially add on therapy. But with this, the asthma is still not improved, then what will you do? Do you consider a trial of increasing inhaled steroid up to 2000 microgram per day and addition of 4 drugs like leukotriene receptor antagonist, SR theophylline, and beta 2 agonist tablet? So you have to give the beta 2 agonist in the tablet form because inhaled is not working. You will give her short and long acting inhaled form, not working. You will start with the steroid and it is not working, then you will increase the dose of steroid along with that other 4 drug like you will add a leukotriene receptor antagonist or beta 2 agonist tablet form. But still the symptoms are not improved, then you have to step up with step 5. In step 5, what you will do? Use daily steroid tablet in low dose providing adequate control. Maintain high dose steroids at 200 microgram. Consider other treatment to minimize the use of steroid tablet and refer the patient for specialist care. If the patient with the inhaled steroid not controlled, then we'll add steroid tablet. But this is the move up to improve control. If the control आपके पास आ जाए, if the control as needed is improved, then you have to move down. Then you have to slowly, if the exacerbation and the symptoms improve, then you have to move down from this. So this is very important table. If you understand this table, then the whole management is very important, that patient what drug she is taking and how you will add on other drugs. So now we will discuss the detail of this pharmacological management. They are concerned held by mothers and their care providers about the potential adverse effect of asthma drugs on their babies and themselves. In pregnancy, women reduce their use of inhaled steroids by 23% and short acting by 13% for stable therapy, and oral steroid for exacerbation by 54%. Because usually in pregnancy, with the effect of progesterone bronchodilation to in one third patient, the asthma improved. Sometimes the dose she's taking that may be reduced, or maybe that she may not need of that if she taking the specific drug, because asthma improved, then you have to stop according to that. This change is enhanced by women is mirrored by doctors who are more reluctant to prescribe corticosteroid both initially and on discharge to pregnant women than to non-pregnant women. So steroid is basically, obviously in pregnancy, steroid have a certain side effects of that may the patient may develop, because we are more vigilant about that. Then with steroid there is increased risk of diabetes mellitus. So in pregnancy we have to benefit outweigh the risks, that whether if she's not needed, then we will avoid steroid. It should be emphasized that it is safer for women to use asthma therapy in pregnancy to maintain good control than to have uncontrolled asthma. Systemic review reported consistently that inhaled steroid, short-acting and long-acting beta-2 agonists and theophylline do not increase the risk of maternal or neonatal outcomes such as preeclampsia, fetal congenital malformation, low birth weight, and preterm delivery. Therefore, good asthma control remains the main throughout the pregnancy. So you have to tell the patient that these drugs are safe and they have no impact on the mother. Pregnancy may modify the pharmacodynamics and pharmacokinetics of some medication. The effect is small and the dose and regime of asthma medication really need to change in pregnancy because of the pharmacodynamics and pharmacokinetics change in pregnancy. So you have to, sometimes the same dose will be effective for that. Observational case control study shown that short-acting beta-2 agonists are safe during pregnancy. By contrast, few data exist on long-acting use alone or combination with inhaled steroid during pregnancy. However, in the limited study, salmeterol and formoterol did not cause fetal malformation, preterm delivery, or low birth weight. So, the safety of long-acting beta-2 agonists prescribed alone in the absence of inhaled steroid have been questioned with respect to asthma control, and thus they should always be used together with an inhaled steroid, ideally in the combination product. So, if you are advising, if you are shifting her the patient to long-acting beta-2 agonist, so in that case you will add the inhaled steroid, because the safety of long-acting beta-2 agonist not studies any done, and it is questioned. Theophylline is safe in pregnancy and at recommended doses. Importantly, serum theophylline level need to be monitored throughout pregnancy, both as a part of routine care, because pregnancy might affect the pharmacokinetics of theophylline. So theophylline usage has decreased in asthma due to alternative therapy, but still has a place in asthma management. So when you are planning for a theophylline, so you have to monitor her theophylline, because the adequate dose is important, because in pregnancy pharmacokinetics are changes, so the drug can be changes accordingly. In some asthmatic disease, control can only be achieved with oral steroid, and systemic therapy are required to manage acute, severe, or life-threatening exacerbation. So in epidemiological studies, oral steroid have been shown to increase the risk of facial cleft or palate in the first trimester. However, this increase is small, less than 0.3%. Sometimes SB may came from this, that what are the effect of oral steroids, so it may cause cleft lip and palate in first trimester, and what is the risk, less than 0.3%. Therefore, oral steroids should still be prescribed when required, but only should be used with caution when there is clinically needed. So in first trimester, better if no need of oral steroid, then you have to avoid, because it will have a certain neural tube defects. Leukotriene modifiers are increasingly used in mild to moderate asthma and have a good safety profile. So you can use, it has a good safety. Therefore, due to lack of data in pregnancy, it is prudent to substitute leukotriene modifier with an inhaled steroids prior to conception at the beginning of pregnancy, alone in combination with long-acting beta-2 agonist. So the safety of the leukotriene receptor are less. So whenever the patient before pregnancy she is taking leukotriene receptor, they said that you have to change to the other drugs, inhaled steroids or long-acting beta-2 agonists, because the safety profile of the leukotriene are still not known. Anti-IgE is the only biological therapy available for asthma. Its effect on pregnancy are unknown. Their therapy should only be prescribed in specialist tertiary asthma centers, and although it is not recommended during pregnancy, it needs to be considered in light of the risk-benefit ratio on individual patient basis with all the therapies in those with severe disease. So basically, IgE cause these type of triggers. So when there is anti-IgEs are available, so they said that they are not safe in pregnancy. Risk outweigh the benefits. So immunosuppressant therapy such as methotrexate and cyclosporine are contraindicated in pregnancy, but in non-pregnant individual, particularly such as oral steroid-sparing agents severe asthmatics. So in non-asthmatic, you can immunosuppressive therapy like methotrexate or cyclosporine can be considered in non-pregnant women. What are the pregnancy issues? The table: poorly controlled asthma confer an increased risk to the mother and fetus if the asthma is poorly controlled. So if it is poorly controlled, that it may lead to increased risk of preeclampsia. The patient may develop increased risk of preterm delivery, miscarriages, and low birth weight. Asthmatic women are at more risk of low birth weight, neonates, preterm delivery, and complications such as preeclampsia, especially in the absence of actively managed asthma treated with inhaled steroid, although the increased risk is very small in women with well control. So there is no contraindication to first-line treatment for asthma when used in pregnancy. Smoking cessation is an important part of general obstetric advice, but important in asthma to reduce symptoms, and efficacy of inhale is reduced in asthmatic who smoke. So you have to tell the patient is used to smoking, so you have to tell that avoid smoking, because it will the effect of steroid will be reduced with the smoking. So whenever you manage the patient of for example in OSCE station, that it came as an exam as an OSCE station, then you have to tell initially that how you will manage the patient. You will manage the patient in collaboration with multidisciplinary team, and you have to tell the feto-maternal risk factors, which we have discussed, that increased risk of low birth weight, preterm delivery, and preeclampsia. These are the feto-maternal risk factor, and then you have to manage accordingly that at what stage patient is. If she's at this stage, step 1, then you have to, and asthma is not controlled, then you have add this inhaled steroid, and if it on the second step, then you have to add the step 3. So these are the stepwise approach toward the management of asthmatic patient. So how we will management of asthma exacerbation in pregnancy. Asthma exacerbation as managed per BTS sign guidelines, which include the use of oral steroids, nebulized beta-2 agonist, and oxygen, as well as other depend upon the severity. So if the exacerbate, so what will you do? You will start her on oral steroids, nebulized beta-2 agonist, and oxygen. So in asthma in labor and delivery, how you will manage this patient in labor. And asthma does not usually affect labor or delivery, with less than fifth of the women experience with an exacerbation during labor. Severe or life-threatening exacerbation are very rare. Prostaglandin PGF2 alpha can cause bronchospasm and need to be used with caution. Whereas prostaglandin E2, for example, prostine, is not associated with bronchospasm, the key point for the asthma during labor. So in that case, PGF2 alpha like carboporous that should be avoided, but PG if you are planning for induction of labor, then PGE2 is safe because it will not cause any effect on the asthma. Peripartum issues. Acute severe life threatening asthma during labor are extremely rare. Women who have been on regular oral steroid may need hydrocortisone during labor, and ergometrine, citrometrine, and prostaglandin may cause bronchoconstriction and should be used in caution. So you have to remember this point that these are the contraindication for asthmatic patient. How breastfeeding. In the postpartum period, there are no increased risk of asthma exacerbation within few months after delivery. A woman's severity typically reverts to its pre-pregnancy level. So, in general, the same medication deemed safe in pregnancy can continue with a negative or uncertain should be avoided. And NSAIDs for analgesia are to some degree contraindicated in asthma and may cause bronchospasm, but in women without intolerance to NSAID, they can be used. So, you have to better to prescribe avoid NSAID because usually post-op will prescribe the patient to Brufen. So in that case, you will avoid. Primary, then you have to refer to primary care physician can manage most women with asthma, but women with severe disease, particularly if systemic steroid are considered, need to manage by respiratory physician. WHO recommend that women should exclusively breast for at least 6 months. Whether the breastfeed child have reduced risk of developing allergy disease in asthma is unproven, but this does not distract from overwhelming benefit of breastfeeding. So